Assalamu alaikum, dear brothers and sisters. I'm Professor Dr. Fatih Kucukdurmaz from Istanbul. I would like to thank to you to the first conference of Somalia Orthopedic Society. It's a great event, and I would like to congratulate all of you as pioneers of orthopedic surgery in Somalia. I know that you're so excited, but I'm also very excited and honored to be with you during this conference, and thank you for invitation again. So I would like to talk about the replacing of post-traumatic hip. First, I'm going to talk about the epidemiology, the types of fractures, treatment alternatives, and the controversies of those treatments, including the implant type, fixation, and approach. The epidemiology wise, there is a bimodal distribution. The first age group that we have to mention is the elderly group, as we expect, and the incidence doubles in this age group, and each decade beyond the age 2 it doubles every decade. And it's higher in white population and smokers. Small body size, excessive caffeine, and alcohol increases the incidence of this fracture. This is one of the very exceptional positive side of being obese is it decreases, being obese decreases the hip fractures in elderly population. And the young patients have hip fracture due to the high energy traumas. But as overall, it's a big problem in the entire world. Every year, it's said that 10 million hip fractures are seen worldwide. When we compare the placement of the fractures in proximal femur, we divide it into extracapsular and intracapsular fractures, and it's like half and half when you compare it. And the proximal femur fractures are often described as subcapital, transcervical, and basocervical, and displaced and non-displaced. And I'm going to talk about mainly the intracapsular fractures, not the fixation. The other thing I have to mention about the hip fracture is the osteoporosis, and the classification according to the density of the bone is, as you can see here, Doer classification is the most popular and reliable method in here. When the type C exists in a patient, the probability of having a hip fracture is significantly increased. So there is many controversies in hip fractures, intracapsular hip fractures, in consideration to the implant type, which can be hemiarthroplasty or total hip arthroplasty. And if it's total hip arthroplasty, it may be conventional or dual mobility. And the fixation is also an issue that we have to discuss about, and it can be cemented or uncemented. And as you know, it's a very popular and hot topic to discuss is about the surgical approach. It can be anterior, posterior, or lateral, or some other approaches are available. When we talk about the implant type, the hemiarthroplasty or total hip arthroplasty are two options. And the conventional or dual mobility is two different types of the total hip arthroplasty, which I rarely use dual mobility, to be honest, and the conventional is usually enough if there is an exceptional risk factor. And when we look at the performed replacement surgeries of the total cohort of femoral neck fractures, the hemiarthroplasty is always more than total replacement. And there's a very good study in the hip arthroplasty, total hip arthroplasty versus hemiarthroplasty, comparing a study in in the New England Journal of Medicine, which is a very popular, high quality, the most important journal in medical field. And in that study, the around 150 patients are collected, and they all had the displaced femoral neck fractures, and either the total hip or hemiarthroplasty are performed. When you look at the results, the outcome at 24th month, the incidence of secondary procedures did not differ significantly between total hip and hemiarthroplasty. But hemiarthroplasty provided clinically unimportant improvement, significantly not important improvement over hemiarthroplasty in function, quality of life. That means, as a result, hemiarthroplasty is a very viable and valid option in replacing of the intracapsular hip fractures. Another study which includes 8 RCTs and a meta-analysis has been done. Altogether, we see that hemiarthroplasty looks a better result in terms of risk of revision. Total hip arthroplasty is better, but rate of risk of dislocation is higher in total hip arthroplasty, and the pain is a little more in total, whereas the cost effectiveness in 24 months looks better in total hip arthroplasty when you consider the risk of revision. So, to be honest, there is no consensus in here, and we have to take the local conditions into account when we decide about the hemiarthroplasty versus total hip arthroplasty in proximal intracapsular femur fractures. And the hemiarthroplasty looks like a very valid option in all the literature, according to all literature sources. When we're talking about the timing, regardless of hip or hemiarthroplasties, it is recommended that the first 48 hours, means 2 days after the event is critical. And it's recommended to have this surgery within this time frame to have less mortality and morbidity. So it's critical. The fixation is another hot topic in this field, and cemented and cementless stems are available. And when we look at the correlation with age of the patient, the quality of bone, we are taking into consideration the cardiovascular complications due to the embolism when cementation is done, and the incidence of periprosthetic fractures are higher in cementless implants, and the duration of surgery and the blood loss are the items that we discuss. And we know that cement increases the early mortality rate and has an effect of the cardiac function. And cementless stems have higher revision rates, and higher pain scores, and higher intraoperative femoral fractures. So when we are taking into consideration of all these factors, cementless stems has some advantages over the cementless ones, and due to the, according to the Cochrane, lack of any significant difference when we take these two techniques, fixation techniques, into account, it is said that there is a lack of evidence in the superiority of one to the other one, but there are some important parameters that we have to discuss in patient base. However, although the cemented stems have some higher complication rates related to the cementing, the risk of cementing can be minimalized if technically we make lavage after we prepare the canal. The high volume of lavage is good for prophylactic technique for reducing the emboli. And retrograde cementing and vacuum suction during the cementing is critically important. And cementing with high and sustained pressuring is also important for a long-term stability of the stem. And based on many other selected literature, the results indicate that cemented femoral stem is superior to the cementless one when the rates of reoperation is compared. So as a result, the cementless stems have shorter operation time. No cement syndrome is seen, and simple operation because you don't wait for cement to cure. However, there is increased risk of intraoperative fractures, increased rate of increased late periprosthetic fractures as well as intraoperative one, decreased hip scars and increased pain, and increased revision rates in cementless ones. So as a result, I can say that cemented fixation is an optimum one, especially when you take the facility or local situation into account and the availability of the implants. About the best approach, which is the best approach as a surgical technique. So best approach is the best one that you perform routinely and have more experience. So when you know a technique better, just do it, because each of them has different types of positive and negative sides. Let me tell the most negative sides of each approach. So the posterior approach has higher rate of dislocation rate, and the direct anterior has periprosthetic fracture rates are higher in that, and the lateral approach has disadvantages of limping after surgery due to the abductor weakness. About the risk factors of the THA, if you want to make a THA, you have to take these into account because these are increasing the dislocation rates. The age more than 80 and being female, and hip fractures, which is the topic of this presentation, prior surgery, so let's say a failed fixation of hip fracture, obesity, and cognitive dysfunction all increases the dislocation rates when you want to make a THA. As a conclusion, so THA looks like a better in displaced garden type 3 and 4 femoral neck fractures in all ages. However, the economical issues limits its use in elderly patients. Cementless stem should be employed in young patients, and cemented stem seems to be indicated in the case of poor bone quality, which is mostly corresponding to elderly population. So, thank you again for the conference. It's my honor performing regularly to the knee course that we're performing in the summer right now. And about the registration, I know it's a little costly, but we have an option to apply for the sponsorship program, which we cover partially or totally the registration fees to the courses in Istanbul Arthroplasty institution. For these, please send an email to the education@istanbularthroplasty.org, or you can send me personal to my personal email, or you can just send me a message through the WhatsApp. It's always open for you. And thank you again for inviting me to this exceptional, great meeting. I'm so excited to be here. Unfortunately, I couldn't be there, but why don't we make similar events in Somalia? I would love to come and make like courses with model bones or some other ways in Somalia. I hope we'll meet in there in Mogadishu. Thank you so much, and I hope we can meet there soon.